Hi everyone, it's nice to be here. Thanks for inviting me, Quentin and Dylan, to this land of amazing snow, culture, food and very clean bottoms. So I'm just going to do an outline, so it's just going to be a case-based approach. I'm hoping to just show some interesting movies and things about, probably mostly about what we do in the cath lab. We'll review some ECGs, a bit about how we manage ACS and some of the complications of revascularization and acute coronary syndromes as well. So I think probably from the crowd, most people are going to know quite a lot of this stuff. But acute coronary syndromes is how we sort of classify myocardial infarction, unstable angina. They're the sort of groups that are under that envelope. So the classification depends on the evidence, on the whether you've got cell injury or not, and ECG changes, and their acute presentation. So it's not chronic stable angina, which is a different thing. There's two types of acute myocardial infarction. There's the ST elevation myocardial infarction, and generally that's associated with complete arterial occlusion or near occlusion. And then there's the non-ST elevation infarction, and the artery is usually narrowed but not occluded, and I apologise for my spelling errors because I was just fiddling around this morning. So unstable angina is new or recent onset of symptoms of myocardial ischemia, so they can present with the same sort of chest pain, but their troponins normal. And so sometimes someone comes in, they've got chest pain, you haven't had a blood test yet, you don't really know, is this just unstable angina or is it a non-STEMI? You give some GTN spray and the pain still goes away and you still have to wait sort of for 3 or 4 hours for that blood test to come back. So just a little brief overview of cardiac anatomy. We'll see if the laser works or not, but your blood, is this my spotlight one? Laser no. Try the spotlight.
Like if you play with the mouse on the thing, it would probably work as well.
Or maybe I'll just point with my finger, hey. So your deoxygenated blood comes back from the body to the right atrium, right ventricle, out the pulmonary artery, oxygenated in the lungs, comes back to the left side. That oxygenated blood also supplies the heart, so it goes for the same oxygenated blood, so it needs oxygenated blood to work. Right coronary, and the left coronary usually divides into the, well, almost always, left anterior ascending and the left circumflex. And the bottom part of the heart is usually supplied by the right coronary artery in about 85% of the cases. So that's called right coronary artery dominant. But in about 15% of the cases, the bottom of the heart is supplied by the circumflex. So that's a dominant circumflex. So this is an angiogram, and a lot of you have seen them before. Put a catheter. You can either go through the leg or through the wrist. My preference is to do it through the wrist. Take a picture, that's a normal artery, so you can see it's nice and smooth. There's no calcification there, so if you have calcification, you can see the artery before you inject. And that's a dominant one, it supplies the bottom of the heart. This is the left coronary. The left anterior ascending is the most important artery, it supplies the most of the heart. And there's a circumflex artery that comes off. Is it going to work? That's the laser, isn't it, Quint? Yeah. So the circumflex comes off here. And because it's we look at it in 2 dimensions, we have to do multiple pictures to show it. So this is another image, and you see the circumflex come down there, and the LAD there. And then we also, usually as part of a diagnostic angiogram, we do a thing called a left ventriculogram or LVgram, where we put a catheter into the left ventricular cavity and take a picture of that. So the ventricles do all the work, and the atria, they just sort of hold the blood in between heartbeats so that the blood's ready to rush in and fill the heart. So the pipes of the arteries, that's a normal one. You get LDL moving through as a response to sort of injury to the endothelium, and you start to develop this atheroma. And how you have an infarct is that usually you get rupture of what's called a thin cap fibrous atheroma. Blood cells stick to it. If enough cells clot, the artery occludes, you have an ST elevation infarct. If it sort of almost occludes or there's bits of blood breaking off, that's when you get a non-STEMI. So that's your thin-capped fibroatheroma. I've got hay fever. Just going to wipe my nose before it drips. That will be uncool. And we can skip through that. So, yucky, clotty artery, and then you end up with that whole artery missing. You fix it up, and there's a huge amount of the heart supplied by that LAD. So, ischemic symptoms. We always say chest pain, but some patients you will say, "Did you have chest pain?" They say, I don't have pain. So it's discomfort, heaviness, tightness. It can radiate to the jaw, can radiate to your left or your right arm. Right-sided chest pain is actually more likely to be cardiac than left side in an adult. They're very different kids. So dyspnea or breathlessness is the other presentation. And some people have no pain, they just sort of feel short of breath. Women or people with diabetes often have more atypical symptoms. It can be sort of an epigastric discomfort. People often turn up, with 3 days of indigestion and actually had a heart attack 3 days ago. Sweating, diaphoresis, occasionally syncope, usually because they've had some non-sustained VT or VF. If it is relieved with rest, it's more likely cardiac than sort of gastric or musculoskeletal. If they've got risk factors, if it gets worse with exertion. But often with that sort of non-STEMIs and things, because it's not such a dynamic thing, it might present differently than that. So, and basically it's an outweigh of, you're not getting enough supply for demand and your heart's saying I need more blood. So atypical symptoms, more often in women, diabetics, chronic kidney disease, patients with dementia, a bit like children. They can't tell you what's going on. Little children. Some of those risk factors are modifiable. Don't smoke, treat your high blood pressure, treat your diabetes, treat your cholesterol. Some are non-modifiable. Family history often is. It's often due to having a high cholesterol, high lipoprotein A. So if you've got a family history, get those things checked out. But as you get older, if you're a male, if you've already had heart disease, you're much more likely to get it again. So we use the ECG as our sort of, it's a bit crude, but it's still what we use as our sort of screening test for heart disease. Different leads in different parts of the chest and the body we use to localise where the ischemia is. So it's good for STEMI, and that's what, for you guys that are paramedics, we rely on you to tell us, what sort of infarct it is and where it is. For the non-STEMIs, the ECG does not localise which artery it is. So normally you have sinus rhythm, you've got, I don't know which one works, your little P wave, which is the atria contracting, your QRS is the bigger ventricle. And then you usually have a isoelectric bit that you have the T wave afterwards, so I should have pointed that out too. So everyone knows, P, QRS, T wave, and usually it's flat between the QRS and the T wave, and that's when you get that, that's what we're looking for, ST elevation in that segment there. So we'll show a few examples of that. Different types of ECG changes are more predictive. If it's horizontal or downsloping, that's bad. If it's upsloping, it's often just physiologic, tachycardic, can be normal response with exercise. So the ECG tells us which part of the heart is involved for your ST elevation myocardial infarction. So the inferior leads that look at the bottom of the heart, here, so 2, 3 in AVF, tell us about the right coronary or a dominant left circumflex in that sort of 15% of patients. The LAD is V1 to V3, plus or minus V4, and the circumflex, plus or minus the diagonal, they can be these lateral leads, can be these inferior leads. So infralateral changes can often be the right coronary artery or the circumflex. So we'll show a few cases. So Mr. DM, he's 79. He gets admitted to hospital with staph septicemia from a right hip wound infection. It's like a pressure necrosis type. He's in hospital for 2 months under plastics. Midnight one night, he has an episode of severe central chest pain. He gets transferred from the rehab hospital to the teaching hospital. And this is his ECG. Does anyone want to have a shot? Put your hand up or just call out what you reckon's abnormal. So there's no ST elevation. Where have I gone? I lost it again. So you just got this T-wave inversion in your septal leads, maybe a smidge at V1, but it's sort of not that impressive.
Isn't there a touch of ST elevation in V1?
Yeah, so just said there's a tiny bit in V1, right? So, 1 millimetre. Yes?
2 months in hospital, I'll call it PE without an ECG.
Yep. It could be. I can't remember if it was on Clexane or not, but it's a good thought. And I mean, you can get these same ECG changes with the PE as well. So anyway, it's not a PE. He might have had one as well, but he didn't. That's not what I got called in for. So then, an hour or two or a few hours into his admission to CCU after coming up from the peripheral hospital in the middle of the night, he does get some more significant ECG changes and his chest pain all comes back. And you can see he's got ST elevation in his septal leads. He's got some lateral changes. Where it's gone. So now he's looking like he's having an anterior infarct. So he comes to the cath lab and you can see on his right coronary artery. I don't know, Dylan, maybe I'll have to go to the spotlight. What is this one going to do?
Try the mouse.
It's not really doing anything much, is it?
Just wiggle the mouse on your screen.
No.
There it is. Yeah, you can see it now. You can point.
Oh, there it is, okay. Yeah, so you can see there's a severe lesion here. And you can see before you're 79, so you can see before you actually inject, you can already see where the artery is because there's calcium there. And then this is his left coronary, and you can see he's got that critical lesion in his LAD. I can't actually see the mouse on my screen, unfortunately, sorry. I do have this spotlight thing, but it's a bit big. So you can see there's that hazy lesion in his LAD, and we take another view and you can see there's a pinhole there where the LAD diagonal bifurcation is. So I don't know if you guys have seen many angiograms. Lots of the paramedics have. They often come and stay in the cath lab when they bring a patient in. So we wire both branches to protect them, put a balloon in and balloon it. Usually the bigger one has a stent mounted on it, and we've already put a stent in, and then we come and do a bifurcation balloon just to sort of move all the stent struts out of the way. And, we get a good result. The patient's pain goes away. So coronary stents, it's just a balloon, and we do the same thing for a balloon angioplasty. We put a wire down and we slide the balloons over the top. They've got a little hole in the balloon, so they just slide over the wire, and you just sort of twiddle the wire down the arteries. You use an X-ray camera. You inject dye generally to show the arteries. The dye can be bad for your kidneys, so we don't want to give too much of it. And the stents come in varying sizes depending on the artery, so we just choose the right size for the artery, and it's really important that you get the size right. If you get the size too small, they tend to block off with clot at a later time, which is called stent thrombosis, which isn't good. So he gets a stent in his right too. Big stent, little extra stent because it was such a long segment of disease. And you get, pretty good result. Got to take your pills. If you don't, the stent can block off. So STEMI, you have ST elevation, requires urgent revascularisation. The earlier you do it, the better. And it represents transmural infarction. And generally, we're looking for 2 millimetres of ST elevation in chest leads or 1 millimetre in the limb leads. So for the right coronary, you can have smaller ECG changes.
Sorry, why do young men have a greater tolerance? It's like more than 2.5 millimetres in young men. Why are we allowed more with men?
I don't know. Is that what the slide said? Oh. I didn't read it properly, did I? It's the definition is this, it's 2 millimetres anteriorly and 1 millimetre inferior leads. But we'll take people to the cath lab when they have less than that. If the signs and symptoms fit, you can get a normal ECG in someone having an infarct. So if someone presents with chest pain, shortness of breath, doesn't go away quickly, sounds cardiac, we'll take them to the lab. Sometimes you get it wrong and they're not having an infarct, but it's better to have a look than to ignore it. So yeah. So second case, Mrs. BS, 90-year-old female living with a daughter. St John activated ambulance in transit. Does anyone want to tell me where the ECG changes are? Everywhere? Yeah, there's quite a few. So you've got your inferior leads. Shall I give another go? Inferior and lateral. Anything else in the ECG? Yeah, so there you can see there's more P waves than there are QRSs, right? So it looks like 1, 2, 3, 1, 2, 3. So you've got like a 3-to-1. Looks like a 3-1 block, but it's not regular. So there's not see the distance between the P and the QRS is variable. So commonly with the right coronary arteries, you also get complete heart block. And it goes away usually when you revascularise them. So sometimes you need to give atropine, sometimes you need to put a pacing wire in. So we're thinking inferior. It's also got a bit of lateral in as well. Could it be the circ? So we go radial, or could it be the right? And it's the right. So big dominant right. You can see that there's a whole lot of, she is 90. I'll stuff it up again, but you can see it's occluded, and there's all this sort of hazy stuff down here. And there's a whole lot of artery missing. So as you get older, it gets much more hard to revascularise you. The left coronary is patent. And so you can see what we've done is we've put this like straw out of our catheter that fits into the artery. There's another tube going down the artery. It's called a guide liner. And it's just when you have really tortuous calcified arteries, you can sort of slide that down the artery to give you a bit more backup so you can deliver stents, balloons, get the artery open. So that's just an example of, this thing that you slide, stick down out of your guide, slide it down the artery just to extend it, and just helps you make things easier for you. So, for a few years we've had these, and they've really made angioplasty much nicer so you can revascularise really sort of cruddy old calcified tortuous arteries and get a good result. So you can see all the calcium in the arteries before we inject any dye, and our left ventricular function actually looks reasonably good. Okay, another case. Where do you reckon that one is? Anterior, yes. You see V1, V2, V3, V4. So which artery is it going to be? LAD, yeah, that's great. So nice, normal, big, or normal-ish. It's a bit irregular. Right coronary artery, it's huge. So it's a dominant right, supplies the posterior descending artery that supplies the septum posteriorly. And you have a severe narrowing there in the LAD. Fix it up, pain goes away. Patient feels good. So here's another one. This one's a bit different. So 72-year-old guy, got laryngeal cancer from smoking, comes in with pulmonary edema and chest pain. What do you think? ECG? Any ST elevation anywhere? So there's just this, got this ST depression. No, another one. This one. So you see here, so you see there's the ST segments are right down there, okay? So you think, well, the artery's not occluded, maybe it's just ischemia. Now, little trick we used to do, before everything was digital, you'd turn the ECG upside down, you'd go to a window and you'd flip it back to front, and you could see that, if I hadn't clicked forward, that actually it looks like there's ST elevation there. So the right coronary artery's got some mild to moderate narrowings. And then you do your left, and he's got this super tight lesion here in his circ, but he's also got a super tight lesion here in his LAD too. And so, we do more and more older people now. When I was a junior doctor, I remember I got really abused by one of my seniors because I called a STEMI, I admitted a patient to CCU who was 70 years of age. Like, what the hell are you doing, 70? And our average age on the CCU is probably about 90 now. And you can see all that calcium in the artery. So you can see before you even inject, where the artery's going. And you can see also, the LAD, this artery at the front, how the distal part of it sort of fills a bit vaguely. So it's like, well, you've got flow in both arteries. Which one should we be fixing here? What's the important thing to do? So we do an LV-gram, so sometimes that can help us. So you can see the front bit of the wall is the LAD territory here. So it's not, see how it's not coming in? See how the dye just hangs there? So you have to worry that, well, actually, even though we thought it was the posterior, the LAD's out, but you can see the inferior bit's out too. And often because it's this inflammatory process, you can get plaque ruptures in multiple territories at the same time. So we balloon it, and you can see when we put the balloon down, it just doesn't dilate. And that's because of that calcium, it's like a concrete pipe. So we go to high pressure, and eventually that yields. You get a good result. And then because we're worried about the LAD, we fix that too. And you can see with the balloon up, there's like a pinhole, it just won't expand. So we go to sort of 22 atmospheres before these balloons rupture. So your car tyre's 4 atmospheres. So it's like a really hard inflation. And so what do? We have some of our tools in our toolbox. We've got a thing called a rotoblader. So it's a diamond sort of tip drill bit. They're just industrial diamonds. I don't think they're expensive. And it rotates, it goes over a wire, and it revolves at 180,000 to 220,000 reps per minute. So it's super fast, and we actually just drill the calcium out. It also sort of cracks the calcium as well, and then that allows us to deliver a stent. It often causes problems with bradycardia, so you have to put a pacing wire in as well. Otherwise their heart stops, which isn't good when you're having a heart attack. So we have all these tools. They're helpful, but they can also cause some problems. So this is another, not quite typical, but 93-year-old lady who's come up from the south of Western Australia. Doesn't really matter what your risk factors are when you're 93, because you're just old and you get things wrong with you. If you go back. So you can see when we do that injection, see that calcium that's there in the LAD, that one coming down the middle of the screen, right? The dye is within the calcium. The calcium is in the wall of the artery. So if you look in the next shot, just watch where the drill goes. See, it's like gone outside that calcium. So it's sort of drilled, and you get this wire bias, and the drill just eats away at the wall, and the whole thing sort of moves out. So we balloon it all, and she's totally stable here, so she still hasn't ruptured her artery. And I've done an angiogram shot, but I've just cut a few out for the talk. And then she says, I don't feel well, and her blood pressure becomes totally unrecordable in about 10 seconds. And you can see when you inject the dye, it's all going somewhere, right? It's going somewhere, but it's not in the artery, right? So she's got, what we've done is we've ruptured her artery, so drilled outside the wall, but you've still got the adventitia outside the wall, so that sort of holds the blood in. And it's not until actually I ballooned it, then the stent wouldn't go down, so I sort of shoved one of those guideliner things down, and that just like ripped a hole in the artery. So what we have to do is drain that fluid that's just rapidly filled the pericardial sac that the heart sets in. So we put a pigtail in called a pericardicentesis. Like most things in cardiology, it involves shoving a needle in, putting a wire through the needle, then shoving things over the wire. And what we do is actually drain the blood from the pigtail, suck it out with the syringe, turn the tap, and then inject it back into a femoral vein. So my fellow's easily just sucking blood and pushing it back into the vein. But, you know, so this is the pigtail, is the sort of the one with the pigtail on the end of it. So we're sucking this blood out with this tube down here. And you can see, you know, she's now got a blood pressure. We have to call the anaesthetist to put her to sleep because he did a bit of CPR and she's got chest pain. So they put her to sleep while we're busily sort of sucking out 50 mils, pushing it in, sucking out 50 mils, pushing it in. And you can see how briskly that blood's filling the pericardium. But then another tool in our toolbox is this thing called a covered stent. So it's a stent with a PTFE lining, so it seals up the leak. You might, sometimes when it's a big hole, you need to use more than one. So we use a couple in there, and then you get the artery open, and everything's good, except she had CPR for a while. She had a bit of a sore chest. But she's still going. This is about, she's now like 96, and drives a car and lives alone down in Albany. So, all right, so I'll show another one. So here's another 71-year-old female. She comes in with severe exacerbation of a COPD. She's up on the ward, she's been there for 2 days, and she develops severe chest pain. So she's got some ECG changes. You guys all seem to be pretty good at them. Who are the residents? So what do you think on that ECG? What leads are problematic? Yeah, so there's V3 through to V5. Pretty much all. Maybe there's a tiny bit inferiorly. So she, you know, we come in the middle of the night, do her angiogram. Pretty good for a smoker. She's got some mild disease. And LAD's patent. So there's nothing there. Is there some small branch that we're missing? So that's just another shot of her left. So we do a left ventriculogram. And you can see on that LV gram what I showed before, you know, the whole heart contracts. But in this patient, the base contracts, but the whole rest of the heart doesn't contract. It's all akinetic. So there's basal hypercontraction, the rest of the heart's not moving. And this is this typical, you know, it's relevant, seeing we're in Japan. So it's a stress cardiomyopathy. So you have some severe emotional stress or physical stress. You get typical chest pain. You get ECG changes. They're often not super dramatic, so it's just sort of 1 or 2 millimetres of ST elevation, often dyspnea, sometimes pulmonary edema. So that's the comparison of her LV gram versus the normal one I showed you before. So it's not an arterial distribution. We don't really understand why it looks like that really. But it's called a Takotsubo cardiomyopathy because this is the Takotsubo. This is a Japanese octopus pot. So it's a pot they use to catch octopus in, and the octopus goes in and then you fish it up and you've got an octopus in it. And so it's described in Japan first. So it's usually postmenopausal women. Often, as I said, follows a stress. And it almost always recovers, but you just have to, well, pretty much always does really. But you still can have things like LV thrombus, arrhythmias. So it's not totally benign. So I'll just show a few more examples of things. I don't know how I'm going for time. So this is you can see here, this is a pericardial effusion. So it's looking at echo now. ultrasound of the heart, and you can see, like that lady where we put the hole in the heart, except you only need about 50 mils to become really shocked when it happens like that. When it happens gradually, you can actually tolerate a huge amount of fluid in that sac around the outside of the heart, and just gradually you start to get, hypotensive, short of breath, tachycardic, and you get this pulsus paradoxus. So you take a breath in and the pulse vanishes, then you breathe out and you feel the pulse again. So if you see someone who's hypotensive and you're feeling their pulse and you notice as they're breathing that the pulse sort of comes and goes, just sort of look at it, work out the timing, and it's a really good sign for a pericardial effusion. Often the JVP is also elevated because the venous return of the heart, the right ventricle being lower pressure, it gets squashed first, the right atrium and the right ventricle. So you can see the heart sort of bobbing around. Sorry, I should have looped that. So this is just a 60-year-old woman. She had a chest infection, and then she had 2 weeks of increasing shortness of breath and came in hypotensive and shocked. And we do exactly what I showed before. Put a needle in, put a wire in. We can use the X-ray to tell that we're in the pericardial sac and not at the pulmonary artery, which is what happens if you push it through into the right ventricle, drain it, and you can see that, it's not working, but you can see that fluid's all gone away once we've drained it. So other complications of acute coronary syndromes, you can get some atrial fibrillation, ventricular tachycardia and ventricular fibrillation, shock, pulmonary edema. You can rupture your pupillary muscles, which is bad. You get acute severe mitral regurgitation, go into sort of crashing pulmonary edema. Then you have those late changes, so same sort of arrhythmias, but you can actually rupture the heart. So you can get a ventricular septal defect, where you rupture from your left to your right heart, and blood goes from your left to your right heart, or you get a free wall rupture. It's usually curtains when that happens to you. So just the last couple of cases. 91-year-old living at home, onset of chest pain at 8 a.m, finally tells their daughter, at about 4 o'clock in the afternoon, arrives in the cath lab at 6 o'clock, previously had a right coronary artery stent many years ago, right coronary is occluded, so they open it up and you get this really crappy flow, right? So you can can't really see where the artery's gone, heart's slowing down, flows. You do your LV gram. And what you see is not much cardiac output because the heart's really stopped. You can see that this blood is just going from their LV into their right ventricle. So they've ruptured their interventricular septum, and just, whilst the procedure's been going on, they've just ruptured it. They're 91, they're toast, unfortunately. Can't do much about that. Another one, another non-so-happy ending. 75-year-old lady, lots of comorbidities, falls, 4 hours of chest pain. When she wakes up, comes into hospital. You guys have all seen lots of these anterior infarcts, ST elevation, there's Q waves. And so this wasn't me, this is one of my colleagues. They do an angiogram, and even though it sort of looks like the LAD is still there, it's not. It's after this diagonal branch here. It's supposed to come down here. So that gets revascularised with stent, and it looks much better. But you can see there's this weird stain out here, right? And it's kind of weird because the operator says, I don't know what it is, because I don't think my wire ever went out there to cause like a little perforation or anything like that. Anyway, the patient goes back to the ward. They're doing okay for an hour or two. Then they have a cardiac arrest. They do start CPR. Someone grabs an echo probe and they've got a massive pericardial effusion. So they get a drain put in it. So you've got a pigtail in there now. They do the angiogram, and you know the arteries are all open, but that sort of stain that was there isn't there anymore. And it's because the bit that was where the stain was is now ruptured, and you can see there the blood is draining from her left ventricle out. This is a free wall rupture, and draining into a pericardium. So again, you know, she's had the blood drained out with the pigtail. She's got two pigtails, one in the LV, one in the pericardial space. And this is her toe, transesophageal echo during the procedure. And you can see there's this flow. I don't know why it doesn't project on the black, you think it would, but you can see this flow through the wall of the ventricle. When I play this one, just in the interest of time, there's another little sort of hole there. And so she's got a ventricular rupture, free wall rupture. And so we call the surgeons about what can we do? Do you want to take it to theatre, patch it up? And they really don't like taking patients to theatre when they've just ruptured the ventricle because they've had an infarct. It's all dead mush. They sew through it and just the stitches all pull through. And this woman, because of her comorbidities, they said, no, we won't take her to theatre. But you know, they're not all unhappy stories. Here's another ventricular rupture. So this is a short axis. This should be a full circle. And there's a hole here with blood that's going straight through to the right ventricle. So it's a pretty big hole. This is someone who's had a late rupture while they're in hospital. They've coped with it hemodynamically, and the surgeons have taken them back to theatre, and they've put a patch. It looks different than there because you don't have that huge hole in the right ventricle, but they've put a patch in here and sealed up that ventricular rupture, so they get to go home alive. So there's some of the complications of treating your acute coronary syndrome. You can get bleeding from us, you know, going in through your leg or through your wrist, from just giving you all the blood thinners. You know, if we put a little hole in the artery, in your femoral artery, your blood can track up behind your SFA artery, up your iliacs, and you can have a retroperitoneal bleed. They're never good because they tend to present, you know, after they've been bleeding for a few hours when they develop shock later on. That's why I like to do it through the wrist. You don't have to worry about that. You can get in-stent thrombosis if you don't put your stents in well, or the patient stops taking the tablets. Generally though, the medications are really well tolerated. 1 to 2% of patients on statins get muscle aches and pains. Sort of 10 times as many people than that attribute symptoms to the statins that we know when we give them placebo and they think they're taking a statin, they get 9 times as many symptoms as they do if they don't think they're taking a placebo tablet. I've sort of discussed all these different differential diagnoses. You can get myocarditis just like in children, but it's generally more benign in adults, myocarditis, because we have troponins, we've got really sensitive tests to detect it. So, do you guys use troponin for kids, Mark?
We do. We're having a discussion before. We use it for pericarditis. It's helpful there. Myocarditis, even in the setting of a normal troponin, if your clinical thoughts are still worried, then you don't take that to the bank. Positive troponins, you take a bunch of people who've been skiing all day. Some people go to troponin. So pericarditis, absolutely. Myocarditis, yes, but it's sort of just part of the diagnostic sort of storm. It's not a be all and end all by itself. The sensitivity and specificity of that test in paediatrics is only okay.
Yes, I think it's a bit better in adults. Just very briefly, our options for treating ACS, they're aspirin. You've got your ADP inhibitors, ticagrelor or clopidogrel. We give a loading dose, then we give you a maintenance drug for that. And generally for the STEMIs, the non-STEMIs and the STEMIs. And then everyone sort of thinks, STEMIs, you've got a worse prognosis. Actually, non-STEMIs, you've got a very similar prognosis. So even though they don't block the artery off, it's just a marker that you've already ruptured a plaque. We've really got to aggressively treat you. And That is